Good afternoon, everybody. My name is Ken DeSergio. I'm a Program Director for Children and Family Futures. Children and Family Futures operates a National Center on Substance Abuse and Child Welfare. I want to welcome all of our colleagues from throughout the country, regional partnership grantees, as well as other colleagues who are implementing trauma-focused cognitive behavioral therapy. The National Center on Substance Abuse and Child Welfare is continuing a webinar series, and this is the second of 3 webinars on evidence-based practices for child welfare-involved families affected by substance use disorders. Today's webinar will discuss implementation, consideration, and challenges, issues related to adoption, adaptation, and accommodation of trauma-focused CBT, Fidelity monitoring and measuring impact and outcomes of trauma-focused cognitive behavioral therapies. In this short period of time, this is obviously not a training on trauma-focused CBT, and it's intended to the audience as a for those who are considering or who are already implementing trauma-focused cognitive behavioral therapy. The National Center on Substance Abuse and Child Welfare brings you this webinar through the support of the Substance Abuse and Mental Health Services Administration, Center for Substance Abuse Treatment, and the Administration on Children, Youth, and Families, Children's Bureau, the Office of Child Abuse and Neglect. The National Center is funded by SAMHSA and the Children's Bureau, and we're proud and excited to bring you this webinar, as well as the other resources that the National Center provides. Dr. Sosna's presentation today, Todd Sosna's presentation, is also supported by the National Child Traumatic Stress Network, which is funded by the Center for Mental Health Services and SAMHSA. So we appreciate Dr. Sosna being here with us today and the support of the NCTSN, as we've come to know it, in making Dr. Sosna available for this webinar. At this point, I'd like to introduce Elaine Stett with the Children's Bureau of the Administration on Children, Youth, and Families, who is our Federal Project Officer for the National Center on Substance Abuse and Child Welfare, as well as for the Regional Partnership Grantee Program. Elaine?
Thanks, Ken. And I'd also like to extend greetings for Sharon Amatetti, who is with SAMHSA and is my co-federal project officer on the National Center on Substance Abuse and Child Welfare. As many of you know, ACYF is committed to facilitating healing and recovery and promoting the social and emotional well-being of children who have experienced maltreatment, exposure to violence, and trauma. And so we are thrilled that we have this time together to hear from our presenter today and to share and learn from the examples that will be discussed. Because I think we all know that an important component of promoting social and emotional well-being includes addressing the impact of trauma, which can have a profound effect on the overall functioning of children and youth. And so ACYF and SAMHSA, I think both are very invested in promoting trauma-informed approaches and evidence-based practice. And so with that, I just want to welcome all of you. Thank you for your work and your time today, and turn it back over to Ken. Thanks.
Thank you, Elaine. Appreciate that. Thanks for joining us today. Okay, I'm about to turn it over to Dr. Sosna, but before I do, I want to introduce him properly. Dr. Sosna is the Senior Vice President for Program Evaluation and Improvement at the Children's Institute, a nonprofit agency providing services to more than 20,000 at-risk children and families annually in the Los Angeles, California area. Dr. Sosna is responsible for directing the agency's Leadership Center, which oversees program evaluation and professional training and improvement activities agency-wide. A former deputy director for the California Institute for Mental Health, he was responsible for evidence-based practice dissemination and implementation, including support for 12 evidence-based practices. Dr. Sosna has held previous positions as a staff psychologist, program director, and assistant director for programs with the Santa Barbara County Department of Alcohol, Drug, and Mental Health Services. So at this time, I'd like to turn the webinar over to Dr. Sosna. Todd?
Hello. It's a pleasure to be able to join you all and to participate in this webinar. I thank Ken and Mariana for inviting me. I'm assuming everyone can hear me? Yes. Okay. So this is a topic that I'm particularly keen on, and going to draw much of what I talk about from my work with the California Institute of Mental Health, CIMH, where I worked at prior to my current position, and where we were responsible for disseminating in the state of California 12 different evidence-based practices involving more than 200 separate sites in more than 40 of California's counties. And trauma-focused CBT was one of the primary practices that we used. And I'll draw from my experience working in California around implementing and sustaining evidence-based practices, for today's conversation. I understand that we have folks on the call from a variety of sites throughout the nation, and that you guys all have in common either that you are implementing trauma-focused CBT or you will be implementing trauma-focused CBT. And I'll be using our time to really talk about implementing and sustaining trauma-focused CBT, specifically evidence-based practices more generally, with model adherence or with Fidelity, so that your clients and the recipients of your services get the optimal benefit from these practices. So in terms of the structure of the presentation, I'll talk a little bit about an overview, the main points, then we'll talk about implementation challenges. We'll talk about specifically the trauma-focused CBT training protocol, a little bit about the issue of adaptations. We'll talk about measuring fidelity. We'll talk about measuring outcomes, and then we'll talk about general strategies for establishing and sustaining evidence-based practices, trauma-focused CBT. Okay, so implementation of trauma-focused CBT. I'm going to need, I don't seem to be able to advance the slides, Jonathan, so if someone could do that for me, or, perfect. So overview. So just in terms of context, there have been a number of initiatives nationally, including systems of care that have been sponsored by SAMHSA, and wraparound initiatives and initiatives that advance evidence-based practices. And when you put it together, what you really see is an effort to achieve the best possible outcomes for our clients by increasing access to services. And so lots of efforts to get kids and families to access services earlier and in higher numbers, and then accessing effective services, specifically evidence-based practices. And so part of the equation is gaining access to services, and part of the equation is that those services that one gains access to are in fact proven to be effective. And in order to make the most of an evidence-based practice, the expectation is it's implemented and ultimately sustained with integrity, meaning with fidelity, so that one can replicate the kinds of outcomes that that practice is known for in the literature. So implementing with integrity really requires a set of organizational supports, and these supports really frame what I'm going to talk about this morning. And so if I were to, by metaphor, if we were talking about farming practices and we had access to some kind of high-performing wheat grain, and that it was, able to grow with less water, so it was good in drought climates, it was able to resist common pests, so that it was hardy, it gave a larger yield so that you got more usable grain for every stalk, that would be great. And then they would transport this seed, to farms all over the country, all over the world. However, you couldn't just throw that wheat seed on the ground and expect to get high-yield wheat. The other part of it is the farming practice. You need to plant it. You need to fertilize it. You need to, tend it so that you get high yield. And that's essentially what I'm talking about in regards to evidence-based practices. Trauma-focused CBT is a practice, when done with fidelity, achieves very good outcomes. However, implementing and sustaining it with fidelity is like the farming technique. You can't simply send staff off to be trained in the practice and expect it to work, nor could you just throw seed on the ground and expect it to grow. There's a whole set of organizational supports, those things that each and every one of the agencies that implement the practice need to understand and bring to bear if, in fact, you want to get the strongest yield. And so the organizational supports that the literature suggests are important could be categorized into the following 6 areas. Administrative oversight, or a champion, an administrative high-level champion, thorough planning, thorough training, practice-specific supervision, monitoring and evaluation of fidelity and of outcomes, and commitment and persistence. So throughout the course of the presentation, I will talk about these 6 areas in greater detail. Advance the slide for me. So common implementation challenges. So based on our experience with really a dozen different evidence-based practices for kids and families, a number of implementation challenges sort of are common. So I'm going to talk about some of those typical challenges, and I'm going to talk about 3 in more detail. The ones in more detail are the bolded items having to do with training, having to do with fidelity, and having to do with outcomes. But I want to share with you a little bit about the other implementation challenges. So one of the issues is selecting a suitable model. In this case, my understanding is you've all selected trauma-focused CBT, and so in the context of this presentation, that's not up for discussion. However, when using evidence-based practices, it's important to ensure that the practice you pick is a good fit for the clients you intend to serve and for the outcomes you're trying to achieve. And one of the things that's inherent in evidence-based practices like trauma-focused CBT is that they're effective, but they're effective for specific populations towards achievement of specific outcomes, and that one needs to be sensitive to that fit if one wants to have a really favorable experience with the practice. Second common implementation challenge is thoughtful and comprehensive planning. It's not uncommon, particularly now when evidence-based practices are increasingly being incentivized by funders, in grants, by payers, for agencies to want to implement those practices, but without necessarily understanding the organizational supports, the farming techniques, in terms of my metaphor, that are important in order for that practice to really thrive in the context of that service delivery system. And the thoughtful and the comprehensive planning has to do with knowing the model, and it has to do with knowing what kind of staff you need and what kind of training you need and what kind of clients are suitable for the practice, and all of the aspects around what it takes to fully implement, which we'll talk about in more detail. And our experience is agencies are often quick to say they'll do something, and then only after they've agreed to do it do they begin to understand the complexities, and that can create challenges. Engaging staff and supervisors. So the whole notion of evidence-based practices is increasingly popular, but also controversial, particularly among mental health practitioners. And the way in which we educate people, in this country, is folks go to graduate school and they get advanced degrees in mental health counseling and social work as psychologists, and they get licensed in those fields. And evidence-based practices are not routinely a part of graduate school education. And so folks come out not necessarily having those skills and having other skills. And sometimes staff perceive an agency's decision to implement an evidence-based practice as an inherent criticism of the training or the practices they have been using. Why should I use that? How do you know what I'm using isn't equally good or better? And the other challenge is supervisors, who often were clinicians and who advance to become supervisors and therefore they have years of experience using a variety of counseling, mental health, psychology practices that may or may not be consistent with an evidence-based practice that an agency has chosen to implement. And so without having staff and supervisors engaged, the implementation of the practice is challenged. And where engagement has been particularly low, we've seen high levels of turnover, people being trained and then not using the practice, and then agencies having to retrain people. And where staff engagement and supervisor engagement is stronger, meaning they're involved in the beginning and they have an appreciation for why the practice was being selected, and perhaps they're engaged, there's an opportunity for them to select into learning and using the model. Perhaps there are financial incentives for becoming credentialed and certified, these kinds of things that then allow those folks that have the interest in the background to lead the way and bring the rest of the therapists and staff along. The fourth area of implementation challenge is arranging for thorough training and accreditation, and there are going to be separate slides, and I'm going to talk about that at length in the context of trauma-focused CBT. The next area of implementation challenge is arranging for practice-specific supervision, and so it's not enough to learn the model, but one also needs to continually be reminded and afforded an opportunity to hone their skills. And it's very common for folks to have clinical supervision, and it's very common for folks to have what I'll call administrative supervision, supervision to things like work expectations and timeliness and documentation. But unique to evidence-based practices is the need to have evidence-based practice-specific supervision. And we'll talk on a number of occasions in this presentation about the notion of drift. Drift is what happens when one doesn't have model adherence or fidelity, when one drifts from the program model. But I tend to think of drift as a ubiquitous phenomena. So, when when the streets are closed because there are potholes and the city is repaving, that's because the street has drifted and they're maintaining it with, with new asphalt. And when your metal banister outside your house begins to rust, that's because the metal's drifting. And when you shave in the morning, that's because your hair grows and the look of your face is drifting. And when you take your clothes to the dry cleaners to get cleaned, it's because your clothes are drifting. Everything without maintenance, left to its own devices over time, begins to wear out. Scissors get dull, roof on your house leaks, the car that you bought needs to have its oil changed and eventually its tire changed. In fact, there are some things we spend more money on maintenance than we do on the actual thing that we bought for the first time. So you may spend more on dry cleaning your suit than you actually spent when you purchased the suit initially. Everything that we want to keep in good order, requires ongoing maintenance, and that is true for evidence-based practices as well. And we routinely do this in our personal lives, but we don't tend to do this as providers of mental health services. And so staff need to have access to practice-specific supervision, not generic clinical supervision, around the particular skills and techniques of that model, in this case trauma-focused CBT. The interesting thing, if I think about my car, is, I think, well, I'll buy an inexpensive car and I'll have to pay a lot for maintenance, but I'll buy a really expensive car and I won't have to pay for very much maintenance because the car's so expensive it must never need, to have the oil changed or the tires replaced. But in reality, just the opposite is true. The higher performing the vehicle, the more one needs to spend in maintenance. And in much the same way, the more sophisticated, the more powerful the practices we use, the more ongoing maintenance, practice-specific supervision is needed. And so this is a little contrary to the way in which mental health practitioners, again, we're typically trained in graduate school, we get licensed by the state, we do continuing education to maintain our license, and we practice. The idea that we need practice-specific supervision around the use of a particular model led by a person who has higher level expertise in the use of that model is not in keeping with standard mental health organizations. Managing attrition and arranging for replacement training. So any mental health agency, public or private nonprofit, is going to have turnover. Any agency is going to have turnover. The agency I work for is relatively large. We have about 1,000 staff, and we lose about 20% of our staff every year. They leave the agency. Some of them stay with the agency, but they take other jobs or they get promoted and they're no longer in the position of a therapist. In this case, let's say a trauma-focused CBT therapist. And so one needs to continually arrange for replacement. You had so many people trained in the model. Those people leave. They need to be replaced by people who either already know the model or who you intend to train in the model. And sometimes we think about starting a program and we don't think about sustaining a program. And sustaining involves the ability to train and retrain or train additional staff as an agency experiences turnover. Advance the slide, please. Managing referrals. And so there's a really interesting phenomena, which is in comes an evidence-based practice, and we look at our clients and we're like, well, all of our clients have trauma. There won't be any trouble finding kids with trauma histories in order to take advantage of this trauma-focused CBT practice. And yet what we find over and over again is that an agency will train a bunch of staff in the model, and then they won't have referrals. And it's not quite clear. There are numerous factors that affect that. I think in brief, the situation is even though an agency sees many clients, all those clients are being seen somewhere. And the idea that we are going to explicitly identify kids with a particular need, in this case trauma history, and then route them to a particular therapist, someone who's trained in trauma-focused CBT, is again not consistent. The agencies I used to work for, we used to rotate. We used to rotate intakes. We used to rotate enrollment of new clients. And so I picked up a new client, now my colleague picked up a new client, and then our other colleague picked up a new client, and then it came back to me again. This idea that one of us specialized in the treatment of trauma and another one specialized in a different kind of treatment, and that we deliberately linked kids with certain needs to certain therapists was not consistent with the way in which the agency managed referrals. And so it's a little bit like going from a generalist practice to a specialty healthcare practice. So you go to see your primary care physician, they see you for anything, an ache, a pain, a sore throat, a broken leg. But if you have a need for specialty care, oncology, gastroenterology, cardiology, then you're going to be sent to a specialist. In some ways, when you have therapists trained in an evidence-based practice, you have created a specialty capacity within your organization, and it requires a deliberate effort in the way in which your agencies manage referrals to get those kids with those needs to those therapists in a timely way. Then the next area is this notion of monitoring of fidelity. How do I know my staff are doing it correctly? And monitoring of outcomes. How do I know I'm getting the level of change, improvement that I expected? I will talk about both of those at length in separate slides. There's this notion of competing initiatives and priorities. One of the things we discover is that agencies that are high performing and looking to have an impact in their communities or applying for these grants where there's innovation and use of evidence-based practices, which means they're probably also involved in other exciting and innovative initiatives. And sometimes what we see is that the people who lead the starting of this initiative are then very quickly leading the starting of another initiative and then another initiative. And that folks at your champion administrative level and your supervisor level are being pulled from initiative to initiative, and in the process exposing the first initiative to drift. In other words, there isn't the sort of persistence of focus on the part of the agency's champion to see these practices all the way through, so that they're rooted and that they're bearing fruit. And finally, developing and communicating realistic expectations. These things take time, and there's a tendency to think, oh, it's evidence-based, I should be able to implement it and see impact quickly. And when the expectations aren't realistic, the tendency is to judge the practice and the implementation of the practice too quickly and too harshly. So to use another farming metaphor, if you plant a fruit tree, when I was a kid, my parents planted apricot trees and peach trees in our backyard, And what you discover is a tree can be planted 1, 2, 3 years and never bear fruit. Trees don't bear fruit the first year you plant them. And so if I'm expecting to see fruit in the first year and I don't see fruit, then I'm like, oh, well, this is a bad tree. I'm going to tear this tree out and plant a new tree. And then I wait a year and I don't see fruit. I tear that tree out and I plant a new tree. And you're never going to have trees that bear fruit. So one needs to be sensitive to the fact that implementing and with success and fidelity evidence-based practices takes time. It takes time for staff to train and to learn and for outcomes to be realized. And impatience or unrealistic expectations about the pace of change or the magnitude of change can be a barrier to overall success. Advance the slide, please. So I'm going to talk now about this topic of training. Now I'm going to talk in general and then specifically about trauma-focused CBT. So real-world behavior. So there is a difference between knowing something, being able to do something, and actually doing something. And that is akin to the difference between teaching something, practicing something, and creating incentives for doing something. Okay, so I know how oil in a car is changed. I've never actually changed the oil in my car. Right? So there's a difference between knowing how something is done and actually doing it. Even if I did successfully change the oil in my car, I'm unlikely to continue to do it on a regular basis because for $25 I can have the shop on the corner do it. And it's going to cost me at least $25 in supplies and trouble, taking the oil out, disposing of it, cleaning up afterwards. There is no incentive for me to actually do it. So when implementing an evidence-based practice, one must teach it. It must be understood. To be fully learned, it must be practiced, and there must be incentives, think organizational level supports, to actually get people to do it the way it's intended. So this is the result of a study that makes this point about knowing, doing, and using. So in this particular case, the skill they were teaching is a behavior management strategy to be used by teachers in a classroom. And the study is done by Joyce and Showers. You see the citation at the bottom of the slide, and was originally shared with me by Karen Blase, who you may know is with NERN, the National Implementation Research Network. And they were trying to teach this classroom behavior management strategy. Think of it like trauma-focused CBT. And the first training component was theory and discussion. The second, and then they looked at knowledge, skill, and use. So if I do a didactic training, essentially, there's 10% knowledge, there's 5% ability to demonstrate the skill, and there was 0% use in the classroom. If I taught it, didactic training, and then I demoed it, so I got up and show you how it was done, 30% knowledge, 20% skill demonstration, 0% use in the classroom. If I teach it, didactic, I demonstrate it, modeling, then you get up and you actually do it. Now you are practicing and I'm giving you feedback. 60% knowledge, 60% skill demonstration, and 5% use in the classroom. If I teach it, I demo it, you practice it, and then I coach you to use it in your classroom. 95% knowledge, 95% skill, 95% use in the classroom. And what's interesting to me is the last two rows. So you can see in the case of practice, there's 60% knowledge and 60% skill demonstration. That is pretty high level, but only 5% use in the classroom. There is a difference between knowing how to do something. I could literally do it. I did it. I practiced it, and I got feedback, and I could demonstrate it. But I didn't actually do it because there weren't the incentives for me to do it. There are many things I know how to do, and I choose to do them depending on context. So there's the language I use at church, the language I use at home, the clothes I wear to work, the clothes I wear on the weekend. I know how to do different things, but I choose based on context. So it takes knowledge, skill, and organizational incentives to actually get people to do what it is you want them to do in a particular context. And so the issue here really, advance the slide please, is that in the case of trauma-focused CBT, it is not a training that agencies need, it is a training protocol. And there are, for trauma-focused, well, this is true for evidence-based practices in general. Different practices are set up differently. Some practices have accreditation or certification, and some do not. In some cases, practices and certification and accreditation are proprietarial, and in other cases they are not. I'm not going to go into all the nuances of all the different kind of training protocols that exist for different models, but I'll talk about the one for trauma-focused CBT. Now, for many years after trauma-focused CBT was widely understood to be effective, there was not a national accreditation model. The developers of trauma-focused CBT, of which there are 3 who are described as the developers, had not created a national accreditation criteria. And so various states and various sites across the nation and actually internationally were implementing trauma-focused CBT and were using a variety of different training protocols. More recently, in the last year or so, the developers of the model have in fact created a national accreditation process, which I'm going to outline here, which comes directly from their website, which you see on the first bullet. The question is, why would you do it? So in some cases, accreditation is required. There are contracts here in LA County that, for example, my agency has to provide mental health services where you must use an evidence-based practice. Actually, trauma-focused CBT is one of about a dozen that you must use, and you must prove that you have been certified by the developers in that practice. So our funder requires certification. There are some states that have statewide systems where that's the case. This is also true in a big child welfare initiative in New York City, where New York City child welfare system is requiring certification in evidence-based practices. In some cases, your sites might be implementing trauma-focused CBT and no one required you to get certified. So what would be the incentive to get certified? In that context, the incentive to be certified would be it provides a thorough level of training and some external indication of a certain level of quality. So it doesn't obligate it, and it doesn't guarantee it, but it does assist. So why get someone certified in CPR? I've seen people do CPR. I could just probably do it myself and never be certified. But if you knew the person was certified in CPR, then it assures a certain level of knowledge and practice and willingness to use, right? And you get a card from the American Red Cross or somebody certifying you in the model. Again, not obligated to get certified, but having that certification suggests a level of rigor, a level of thoroughness, a level of commitment, a level of use quality in the use of the model. So this is the national accreditation criteria. There are 8 steps that must be met. So the first criteria is the practitioner of the model must have a master's degree or higher in a mental health discipline. So the developers assume a general level of graduate school education. They must be a licensed professional in their home state. So every state has its own kind of licensure. They must have completed the 10-hour online course. And if you are not familiar with this, it's called Trauma-Focused CBT Web. If you were on Google and you put in Trauma-Focused CBT, it would be your first link. It's hosted by the Medical University School of South Carolina. It is free, and it is a prerequisite. And one of the 8 steps for accreditation is that you take this 10-hour course. And when you complete it, you get a certificate. The next criteria is participation in a live, minimum 2-day training conducted by one of the 3 developers, Tony Manarino, Judith Cohen, or Esther DeBlinger, or one of the approved national trainers. And there was at one time, the 3 developers did 3 rounds of training for trainers. And out of that came about 40 or 50 individuals who the developers acknowledge as national trainers. And so that's who they're referring to. So that's the criteria, a 2-day training. However, in acknowledgement of the fact that some states, California being one, actually under the work I did at the California Institute of Mental Health, established a statewide approach to training of trauma-focused CBT using a learning collaborative model that predated the national accreditation. So the developers are allowing a statewide learning collaborative system that involves at least 6 months duration and includes a developer or one of their national trainers as a substitute for the 2-day training. And so some states have that. California is one. Otherwise, it's a 2-day training. Participation in follow-up consultation or supervision. So they're assuming that after the 2-day training, there'll be twice a month calls for a minimum of 6 months. That would be 12 calls, or once a month for a year. That would be 12 calls. This is a group of therapists who have completed the online course and who have completed the 2-day training and who are now on a consultation call with a national trainer. And so they have to participate in 9 out of those 12 calls. And again, they make a qualification for states like California that had their own learning collaborative model. Oh, I have the screen working. Thank you, guys. And then they require completion of 3 separate trauma-focused CBT clients, at least 2 of which included an active participation of a caregiver or a caregiver person like a foster parent. And as you know, trauma-focused CBT has client-specific components, so one-on-one with the client, and then parallel sessions with caregivers. And so that's the reference. And they have to use at least 1 standardized instrument to assess trauma-focused CBT progress, so one of the outcome measures. And they must take and pass a certification program knowledge-based test, which you'll find on the website where this whole thing is, this website right here, their national accreditation website. You can find that test. And so, and in fact, on their website, you will see a list of all of the therapists they have credentialed. So if you look at the Joyce and Showers study, it's didactic training. That's the webinar. That's the 10-hour webinar training that they do, plus the 2-day didactic training. And then it's practice. That's 3 clients and consultation calls with a national trainer. And then it's up to you, the agency, to create the 3rd necessary component, which is the incentives in the context of the organization to get that therapist who now knows how to do the model to actually like it and do it with Fidelity on an ongoing basis. So that's that. So when we talk about thorough training, that is from a national standard for trauma-focused CBT thorough training. I'm going to talk about adaptations in a moment, but Mariana, what if I take a break and see if there's any questions about the other more general implementation challenges or about this notion of thorough training and accreditation?
Okay, great. Thank you, Dr. Sosna. You know, one of the questions that has come up in our planning of this webinar has been that many of our attendees work with parents who might be in early stages of substance abuse treatment or recovery. So we're wondering if you have any specific recommendations about how we might be able to phase in TF-CBT with families where parents are in these early stages of treatment and recovery.
Sure. So, so trauma-focused CBT, as I was mentioning, involves 12 to 20 sessions, depending on the nature of the trauma and the complexity of the circumstances. And sessions follow the acronym PRACTICE, P-R-A-C-T-I-C-E. And each letter refers to a different technique and they're used in an order. So P in practice is psychoeducation, and R is relaxation and affective modulation, and it's cognitive restructuring. It spells out the acronym, refers to the interventions. And the idea is that you do a session with a child, maybe 45 minutes, maybe slightly shorter, maybe slightly longer, depending on the age and developmental level, and then you do a parallel session with the parent or the caregiver. And that's the strongest way to implement the model. And you do parallel sessions until towards the end of the course of treatment, where you then do joint sessions, child and their parent or caregiver, and the child shares with the parent the trauma narrative, which is a very key part of overcoming the trauma symptoms. And then there's sort of a relapse prevention. What are we going to do to keep things keep things safe going forward? And so that's ideal. However, 2 important considerations. Trauma-focused CBT has very good outcomes even if the only sessions provided are with the child, even if there is not a caregiver who's available. The second issue is that the sessions begin parallel. And the most significant issue would be the joint session. And if a parent, for any reason, substance abuse, active substance abuse being one reason, wasn't going to provide the right kind of supportive response to the child in the joint session in regards to the trauma narrative, then that session does not have to, can be skipped. In other words, you never have joint sessions. You only have parallel sessions. And that's because you want to make sure that the child doesn't share their trauma narrative and get a negative response from the parent. And if you didn't have confidence that the parent was going to be able to do that, then you could opt as the therapist not to have that joint session, and that's perfectly fine. So the model builds in some ways in which to gauge the nature of the response you're going to have from the parent. The other thing I would tell you is, you know, it often seems like there's never a right time to do something. And so the trauma-focused CBT people talk about COWS, crisis of the week, or CODS, crisis of the day. And what happens is every time you're about to get to the focus of treatment, they tell you, oh, by the way, I'm being evicted from my apartment. Oh, by the way, you know, I had this incident. Oh, by the way, I lost my job. Oh, by the way, my child's getting kicked out of school. And one never gets to the focus of the treatment because one is continually addressing the COWS, the crisis of the week. And that could be related to a caregiver having a substance abuse. It could be related to a great many other issues. Interestingly, trauma-focused CBT trainers teach therapists how to deal with COWS. I would tell you this is important in general across the board. Ann Garland is a researcher from the University of San Diego, UC San Diego, and she wanted to compare the difference between evidence-based therapists using an evidence-based practice and general therapists just doing therapy in the real world. And she collected hundreds of audio tapes of actual sessions and then rated the techniques used in the sessions and then compared them to what the research says is most effective. And what she discovered was that many of the things regular therapists were doing were consistent with what the research suggested was effective. However, they were doing too many different techniques in one session, and they weren't following up on the technique session to session. There wasn't continuity and focus. Essentially, what she finds is that they were watering down the practice, doing too much without enough focus or follow-through. So if therapy were, you know, making orange juice from frozen concentrate, and you're supposed to put in 3 cans of water, it's as if we're putting in 5, 6, 7 cans of water. It looks orange, but it tastes like water. It's no longer orange juice. And so this is this phenomena of COWS and this phenomena of being distracted by a myriad of other kinds of issues that impinge on a child and a caregiver and the dyad or a family. And the issue really is agencies and systems need to have the ability for multi-pronged responses, but not in lieu of doing the evidence-based treatment. So trauma-focused CBT can proceed with a child, can proceed with a child and a caregiver in parallel sessions and hopefully in joint sessions, and that doesn't have to wait while one addresses other issues. However, one does need to address other issues, but not in lieu of doing trauma-focused CBT. One needs to have the capacity to deal with the crisis of the week, you know, schedule a separate session with a parent, follow up on separate issues, gauge how much and when you involve them in the trauma-focused CBT training. But don't abandon or forestall starting it, and certainly don't water it down because these other issues are co-occurring in time. Otherwise, one never gets to the point where one equips the child and the caregiver to appropriately have the skills, interpersonal, personal, to deal with the trauma and to build the resiliency to address it, you know, going forward. The other thing is that developers are acknowledging the issue of complex trauma, which is to be distinct from, you know, single or multiple single event kinds of trauma. And so there's a little bit of an adaptation that can be done with the model when one has complex trauma, meaning one lives in a highly violent community where one sees, you know, violence in their home or in their community or in their school, and that's not going away. And so in some ways, the individual is being re-traumatized. The goal there then is to build a kind of resiliency that buffers against the effects of that trauma that you see in things like the ACEs study. And in fact, ACF has an initiative dealing with complex trauma. And so this, you know, there's an adaptation to trauma-focused CBT for that. So kind of a long-winded answer, but hopefully helpful.
Great. Thank you, Dr. Sosna. No other questions at this time.
Okay, so let's talk about adaptations. So I just put a placeholder slide in here because it's sort of a big topic, and I'm just going to introduce it and share some thoughts about it, but we can't really do the topic adequate justice in the context of the time we have for this one webinar. And I also want to make, I want to use some very specific language. So I want to make a distinction between adoption, adaptation, and accommodation. And so adoption is the term that usually refers to implementing a practice with fidelity, as intended, so that your implementation of the practice looks very much like the implementation used by the developers of the model. And the notion is the more closely one does that, the better outcomes one gets. Adaptation refers to a change in the model, some fundamental component of the model, whereas accommodation refers to a cultural or ethnic adjustment to the model, languaging, the way in which it's explained, the nature of the techniques that are chosen, but the fundamental aspects of the model are not changed. So an accommodation retains all of the core components, but adjusts for culture and ethnicity and language and individual differences in clients. An adaptation is a deliberate adjustment to one or more core principles of the practice. An adoption is implemented as intended. So in my experience, agencies who are new to a practice are wise to adopt, to implement as intended before they contemplate adapting. Sometimes what happens is we think that we know how to improve something and we want to make an adjustment before we've actually even learned to do it the way it was intended. And that turns out not to always work out well. There are a variety of kinds of adaptations one might consider. One might consider an adaptation because a child is young. One might consider an adaptation because of culture or ethnicity or language. One might consider an adaptation because of the nature of the trauma or some other reason. And what the research suggests is that trauma-focused CBT is a very robust practice. So random clinical trials have been conducted, numerous random clinical trials in different states with very diverse populations across very different kinds of providers and internationally. So one of the national trainers who I think is particularly exemplary is Laura Murray. She was at Johns Hopkins. She may still be affiliated with Johns Hopkins. And she has done research with trauma-focused CBT in Cambodia and in sub-Saharan Africa, dealing with very different kinds of trauma related to civil wars, related to extreme kinds of abuse, and found very strong outcomes. And so trauma-focused CBT as a model is proving to be very robust. There are some adjustments one makes when one takes into account developmental level, but that's an accommodation. There are some adjustments that one makes when one takes into account individual difference. That's an accommodation, not an adaptation. So a choice of relaxation technique. For a small child, I might use the dry noodle, wet noodle technique. I'm a dry noodle, I'm a wet noodle. So I'm tense, I'm relaxed, like a progressive muscle relaxation. Whereas for a teenager, I might use a modified version of yoga or mindfulness as my relaxation technique. So there's a developmental adjustment. Same thing with cognitive reframing, same thing with the processing of the trauma narrative. There are accommodations that are made, but those don't fundamentally change the model. The other thing one should know is that an adaptation is not always necessary just because clients are different in some way or another. And so Stan Huey, he's a researcher at USC, did a meta-analysis to look at evidence-based practices for kids from ethnic minority groups to answer the question of whether or not they were responsive, whether they got similar kinds of outcomes. And he looked at adaptations and the effectiveness of those adaptations. And what he discovered was that the evidence-based practices many of them prove to be very robust, meaning they have comparable, favorable outcomes across diverse clients. The second thing that he learned was that in cases where adaptations were made, real, authentic adaptations specific to particular ethnic groups, they didn't universally improve outcomes. And there's a study of an adaptation that was done for an evidence-based practice for an indigenous Hawaii population, and what they found was the outcomes were worse in the adapted model, even though it was sensitive to cultural issues and it was adapted by people from that culture. And I think the issue is this, that there are many things that make us different and many things that we share in common as people in different, all across the country, and for that matter, all across the world. The issue really is, what is the active ingredient that makes the intervention effective, and do we believe that that is mediated by factors that we have in common or factors that we make us different? So I can look and see that we, people have different skin color. The question then is it relevant? It's relevant if I believe the effectiveness of the treatment is mediated by some difference associated with the color of a person's skin. It's not relevant if I think that what makes my treatment effective is mediated by something that I have in common, independent of the things that make us different. So when I think about aspirin, aspirin is a painkiller for many people. Do we believe it's mediated biologically by something that is common to people or something that is different to people? In the case of aspirin, I would say it's robust. It doesn't seem to be mediated by differences, although there are some examples of medications that do seem to vary by particular groups. And so the question really is not, are there differences? There are certainly differences across people. The question is, are the differences relevant in the application of this particular treatment model? Again, I would refer to Laura Murray's study that suggests that, in fact, the model is extremely robust and works across very different communities of people with different languages, very different belief systems, very different living situations, and the model has proven to be rather effective. So is there a need for adaptation? Maybe. That's an empirical question. Stan Huey concluded that individuals should implement the model as intended and only decide to adapt if they have evidence to suggest it's not working, as opposed to assuming that it must be adapted before one has experience with the model. Marianne, if there's specific questions on adaptation, I can take a moment, or I can move on and talk about Fidelity.
I would say go ahead and move on to Fidelity. No questions at this time.
Okay. So Fidelity. We're going to talk about Fidelity and outcomes as a related topic. So the idea with model adherence is, if you implement something with Fidelity, the assumption is you will replicate the outcomes that were reported in the literature associated with that practice. Alternatively, if you collect your own outcomes and your outcomes replicate what's reported nationally, then of course you're confirming that you're getting the same outcomes that are reported in the literature. Turns out that measuring fidelity is trickier than people think. So one of the common ways of measuring fidelity is a self-rated tool. That is, I'm a therapist, I'm trained in trauma-focused CBT, and I rate myself and the degree to which I'm using the model as intended. That's great, as long as the person isn't feeling any pressure to indicate, ratings in one way or another. The alternative way to do it would actually be to observe the session. I could sit in on the session and I could rate you. A third way of doing it would be by proxy. I could have you audio tape or videotape the session and I could rate it from a distance. So obviously the audio taping or the videotaping would be the best, actually sitting in on the session, would be the best evidence. I could literally rate whether or not you were adhering to the model. That would assume we had access to that kind of thing, which is challenging, and it would assume that we had rating methods that were validated. And ratings for fidelity tools for evidence-based practices is actually just developing. Multisystemic therapy is probably furthest along, but in fact the agency I work for, CII, is currently involved in a research study being conducted by MDRC, which is a research institute based in New York, to review 1,800 trauma-focused CBT audio tapes in an effort to validate a Fidelity tool based on reviews of audio tapes of actual trauma-focused CBT sessions. So it's in development. However, there is a tool commonly used by therapists. It's called the Brief Practice Checklist, and it's completed by the therapist at the end of every session. And then it can be reviewed if I'm doing training and I'm doing those consultation calls that we're talking about in the national accreditation, then I can share my brief practice checklist with the national trainer. If, on the other hand, I have practice-specific supervision, which I talked about earlier and we'll talk about again in a little bit, I can share that with my trauma-focused CBT supervisor. So it has utility that way. In the material that was sent to everybody, you have the actual PDF of this tool. However, I put in a screenshot just to show you. And so it's probably hard to see, depending on how big your screen is, but there's one 2-page front and back sheet that's good for 20 sessions, and that there's one sheet for every client. So I'm seeing a client, I'm the therapist, I'm doing trauma-focused CBT, I write my name, I write my client's name, and I start doing therapy. Every column refers to a different session, 10 sessions on the front page, 10 sessions on the back page, and down the first column, every row corresponds to a different technique in the trauma-focused CBT model, and you can see the practice acronym, PRACTI, works its way down the page, and then you see we've blown up some of the elements. And so I indicate the date of my session, and I indicate whether or not I have done those techniques. So it's possible for someone to review to see what I've done and how it's going. So it is a proxy measure. I think it's particularly good for training. It's excellent for practice-specific supervision. And it's an indirect measure of fidelity. However, if an organization puts a lot of pressure on this tool, then you may have the unanticipated consequence of staff feeling like they need to represent that they're doing things that they may not actually be doing because they feel like they're being judged. But the brief practice checklist is very commonly used in training and in supervision. And actually in the study I refer to that MDRC is conducting, they will be correlating the brief practice checklist against an audio tape review measure to see whether or not the brief practice checklist is a validated measure of fidelity. But it is often used that way. However, given that fidelity is a challenging thing to measure, it's also important then to measure outcomes. And if you put the two together, then you have much more information. And so we routinely use a two-pronged approach here. LA County actually requires this, and the state of California implemented this for trauma-focused CBT sites. It's not required, but it's encouraged. And that is to use one trauma measure and one general measure of mental health functioning administered at the start and the end of the course of trauma-focused CBT. And based on that, you can see whether or not you're getting improvement on trauma symptoms and on other symptoms like disruptive behavior or anxiety. So one specific measure, one general measure. The specific measure that's used in the state of California is the Post-Traumatic Stress Disorder Reaction Index, also sometimes called the UCLA Trauma Index. And the general measure we happen to use in California and in LA County is the Youth Outcome Questionnaire, some measure developed from the University of Utah. It's a general measure of mental health functioning. Would be similar to the Child Behavior Checklist or the BASC or the CAFIS or any other number of sort of general measures. And then you're able to generate reports. We do two things, and this is just on the slide an illustrative example. So one thing we do is every time trauma-focused CBT is started, our therapists administer these measures, and we send back to our therapist a report, like a sample of the graphs you see on the screen. So these are 3 of the subscales and the total score from the PTSD-RI. And this is the report that would be client-specific at post-treatment. So you see change pre to post. This is just an illustrative example. But we ask our therapists, who asks their clients to complete these measures. We then score these measures, and we send them back these scored reports, client-specific for them to share with their client. In the same way, if I was trying to lower my blood pressure and I engaged in a diet and exercise regimen, I would then want to have my blood pressure taken periodically so I could see my progress. So this is a client-level report. This happens to be a second report, not specific to trauma-focused CBT, that has to do with resiliency. That's relevant to some other programs we have. So I will not belabor that. And then we also do program-level reports. And so with the program-level reports, we aggregate data. In this case, 282 kids. They have an average age of 10. We're showing ethnicity here. And then we show change. And so the graphs represent change pre to post on average scores. So if you're reading the chart on the upper left of this graph, you see we had 99 parents complete the PTSD-RI on their children, and the average score went from 21 to 13. That is a statistically significant improvement. At the child's own rating, it went from an average of 28 to 16, also statistically significant. You see a second table that says YOQ. That's the Youth Outcome Questionnaire. Again, you see average scores changing pre to post. That red horizontal line refers to the clinical cutoff for that tool. And then down below you see what's referred to as a reliable change index. The particulars of the report are not important. What is important is that we have a way of determining whether or not, in fact, we're seeing improvement on trauma and other kinds of behaviors as a result of the trauma-focused CBT treatment. And the goal here is client-level reports to be shared with clients by therapists and program-level reports to reassure us. If I wanted to relate my fidelity to my outcomes, then I could correlate my brief practice checklist ratings, or I could look at staff who have been recently trained versus staff who have been certified. I could look at staff who use the model with just a handful of clients as opposed to staff who have lots of experience and have used it with dozens of clients. What I would expect to see is that those staff who have more thorough training and experience using the model should show better outcomes, and that would be presumably mediated by Fidelity. In the handouts I sent you, I included a report from California. This report actually is developed by the California Institute of Mental Health, and it's an example of a statewide report. Again, I know you have sites all over the country, and so some of you may or may not be able to be part of a collaborative, but this report summarizes data from 74 different providers in the state of California over a number of different years, and includes data for 19,000 recipients of trauma-focused CBT, and includes things like how many of them start but don't finish. It talks about length of treatment. So in California, the average length of therapy is 25 sessions over 32 weeks. I will tell you at our agency, we average 20 sessions over 25 weeks. So we do it in a manner that's more consistent with the model. The model expects 20 to be the upper limit. It talks about percent improvement and a variety of the things that I was sharing in the slide. So this is statewide data. I can compare our agency's data against the statewide data as a benchmark. So that was sent to you as a reference. But again, if one is interested in knowing, are we doing something with model adherence, one can use something like the brief practice checklist. However, one would also be wise then to have some kind of an outcome measurement process like the one that CIMH does for providers in California, or like the one we essentially do the same thing but within our own agency, so we have some kind of a reference. Mariana, I can stop and take questions if there's any questions about fidelity or outcomes.
There are a couple. You spoke a little bit about the use of specific tools. You said one trauma-specific tool, one general mental health tool. Could you just briefly review again the names of the tools that you identified? And
Sure.
Then additionally for that, are there any specific tools you would suggest for that younger population? So maybe the 3 to 5-year-old children.
Sure. So in fact, you sent me, Mariana, in preparation for this webinar, a list
Yes.
of measures. And so you guys have already a very good list here. So the measure we're using which we use throughout California and is actually required by anyone who does work in LA County, is the UCLA PTSD RI, which stands for UCLA, the university where the developers are, right? The Post-Traumatic Stress Disorder Reaction Index, that's RI. And there's a child version, an adolescent version, and a parent version where the parent rates the child. And it is actually the last item on the list you sent me. So you have that measure listed. The other measure that we tend to use, and this measure will go down to a parent can rate their child as young as 4 on the PTSD-RI, and a child rates themselves if they're 7 or older. So it covers a very large age range. However, it doesn't cover the 3 to 4-year-old. That's the gap. And if I was looking for a trauma measure for very young children, I would use the Trauma Symptom Checklist for Young Children, which is actually the first measure on the list that you sent me. So you have both the trauma-specific measures. There are some other trauma-specific measures, but those are the two that I've seen most used. And then I mentioned the Youth Outcome Questionnaire, which is the general measure that's used and, again, required by providers in LA County. However, I see on your list the Child Behavior Checklist. That's the Achenbach, is a perfectly good measure. I see for young children the DECA-IT. That's the infant and toddler version of the DECA, which is a good measure for infant and toddlers in terms of a general measure. I see the I see the BASC, which I mentioned before, the Behavior Assessment System for Children, perfectly fine general measure. And yeah, those would be the ones I see that you have listed that, you know, that would fit general measures. So you actually have them here. I think the issue with outcome measures is not to go overboard. We like one specific measure. If I don't see change on a trauma measure, then I'm probably not doing much with trauma symptoms. And a general measure, because sometimes what you see with kids who have trauma histories is disruptive behavior and anxiety and risk-taking behavior, and I would like to know if I'm having an effect on those behaviors as well. The research on TF-CBT says that the model has 2 related but independent impacts. The part of the model that refers to the PRAC in the acronym practice, that's psychoagitation, relaxation, affective modulation, and cognitive restructuring, improves behavior. And the trauma narrative, which is the TICE, addresses trauma symptoms. And so trauma-focused CBT actually shows improvements in both disruptive behavior that you sometimes see acting out and trauma symptoms like the experience the child has that, you know, would be more internal, dread, hypervigilance, distractibility. Both are improved by TF-CBT, but by different components of the model. Another question?
Great. At this time, I think we can hold off. I'll let you finish the presentation,
Okay.
and we have a couple questions for the end.
All right. I'm going to,
Thank you.
Sure. I'm going to wrap up with these last 2 slides, and then sort of highlight what I think are sort of the really critical pieces. I make a distinction between establishing and sustaining. Establishing is when you start something brand new, and sustaining is ongoing. And I think that agencies have a tendency to put a lot of emphasis on starting and not necessarily as much emphasis on sustaining, and the result is drift. At any rate, establishing. So establishing an evidence-based practice, trauma-focused CBT in this case, these are the sort of the key ingredients from our experience. One is having an administrative or management level lead or champion who's learning and using the model. What we find is that this person needs to be high level, needs to have the authority to commit resources and to make decisions about how referrals are handled, authorizing training, authorizing supervision, needs to be placed in an agency to affect change and to ensure that the practice can be learned and used appropriately. And so we're going to call that an administrative champion. A second thing is a concrete intervention-specific implementation plan. So again, it seems to be in our experience, people spend a lot of time seeking opportunities to use these models with grants and foundations, but then once they're awarded, they don't necessarily spend the time to lay out a concrete written implementation plan. that involves understanding the model. How does it work? What does it take to be successful? Selecting staff, preparing staff, selecting supervisors, preparing management structures, being clear about how referrals, where kids get identified as needing trauma-focused CBT and then get assigned to trauma-focused CBT therapists, and overall oversight to make sure all of that happens. Understanding the training. What does it take to learn the model? What kind of practice is necessary? Is there accreditation? What options are there for replacement training? And then setting realistic expectations so that the tendency is for people to expect too much too soon, and someone needs to sort of modulate that. Engaging providers, staff, supervisors at the outset, talking about the model, why it's being selected, why it's being used, even making it sort of an opportunity that people have to compete to get an opportunity to be trained in the model, as opposed to what we've seen in many places where people sort of assign people to learn the model and people don't necessarily have the buy-in, and that can be a rough start. Focus on fidelity from the outset. So you talk about model adherence and this notion of adaptation and accommodation, and that using an evidence-based practice with fidelity is not a rigid limiting process. It is a quality assurance process. So for many years I was a consultant, and for many years I traveled. And one of the things, you know, when you travel is you're in planes taking off and landing all the time. And what you discover is there must be a playbook that all of the pilots and all of the planes and all of the airports and all of the country do the same way. A pilot can't decide they're going to take off to the east one moment and the west the next moment. They can't decide they're going to take off because they're ready even though there's a plane in front of them. The way they inspect the plane, the way you take off, the way you land is all orderly. It's all prescribed, and everyone follows it. That's quality. That's when you get on the plane, you know that you're going to end up, you know, where you intend to be safely. There's tons of examples of where we rely on adherence to a strategy, to a process. Interesting study that was conducted with surgeons where they were asked whether or not they would be willing to use a surgical checklist, a checklist of things that they needed to bear in mind when conducting surgery. Many said they would, but a good minority of them said no, they wouldn't. However, when asked if they themselves were getting surgery, would they want their surgeon to use a checklist, virtually all of them said they would. The idea of fidelity is not about being rigid. It's about ensuring that you end up with, you know, high-quality programming. It's like a recipe. My grandmother has chocolate chip recipe. It's better than Toll House. It's the best ever. If I'm going to replicate her cookie, I have to use her recipe. If I start messing with the proportions of the ingredients, I end up with an entirely different cookie. One needs to use the full training protocol and maybe certification if that's relevant. One needs to start the model quickly after training. This is one of the biggest mistakes. We have seen tons of agencies who train lots of people. Sometimes they think, well, I have to pay for the training. The more people I put into the training, the better it is. Not necessarily the case. If attending the 2-day training or completing the webinar is like that didactic training in the Joyce and Shower study. If I don't turn around and practice it, I will not be able to do it. I will know it, but I will not be able to use it. In order to use it, you must practice. Didactic training alone confers almost no ability to actually use. And if one doesn't immediately start to use it, then very quickly there's drift. Initiate program performance evaluation from the outset. Use one measure, like the PTSD-RI, or use 2 measures, a general measure and a specific measure. But don't start without using measures. And finally, maintain momentum. Expect and plan for interrupted progression. These things don't go smoothly. Don't let people believe it's going to go smoothly. And then when you have to adjust, everyone expects it. In terms of sustaining, the elements are very similar. Maintaining that administrative champion. Our experience is there's a very active champion when a program starts, and very quickly that person fades away and programs drift. You need intervention-specific supervision, even for people who are fully trained and certified. At our agency, every single TF-CBT therapist, and we have over 35 people trained in that model, therapists, they must attend trauma-focused CBT-specific group supervision twice every month for as long as they use the model, and they're all certified. It's not about, I question how well you do it. It's about you use the model, there's compassion fatigue, there's secondary trauma. You need to be able to hone your skills. It's like a knife that gets dull. It needs to be sharpened. The intervention-specific supervision serves that purpose. Routinely monitoring fidelity and outcomes. All of our staff do the brief practice checklist. Again, it doesn't matter if they're certified. They use the model, they use the brief practice checklist, and it's discussed in that supervision. All of our staff use outcome measures. Program performance evaluation, like that report you saw from CIMH. Commitment to replacement training. If I have staff turnover, I can't just bring somebody in and have their buddy train them. I need to train them using the online course. I need to train them with a national trainer and give them that 2 days. And then I can put them in with one of my supervisors. I can't just say, hey, you know, here's a colleague of yours who's been doing it. They'll explain to you how to do the model. That is not a sustainable strategy for replacement. And you need to be able to dedicate the time and money to the training activities. So like I was saying, if you buy an expensive car, then expect to pay maintenance. If you buy a nice suit, expect to pay dry cleaning. You know, these things are part and parcel of maintaining anything with integrity. I'm going to leave you with my favorite metaphor about sustainability of evidence-based practice. And when I was a kid, I grew up in San Diego, and I have 2 brothers, and our parents would take us to the beach. And we would go to the beach, and they would camp out on the sand, and they would have their umbrella and their cooler, you know, and their tuna fish sandwiches with wax paper, and my mother would have her ice-cold tab. So now I'm dating myself. And they would tell us to swim right in front of them. Go into the water right in front of us where we can see you. And then they would get to chatting and eating their tuna fish sandwiches, and we would get to, you know, to bobbing in the water and splashing each other. And the next thing we know, we would look up and we couldn't see our parents. And our parents would look up and they couldn't see us. And it's not that we didn't listen, it was that the ocean has a current. And we had drifted, and while playing and bobbing and splashing, we hadn't noticed that our position in the water had moved, and my parents, chatting away, had been distracted and hadn't seen us go. And so there are 3 things in the beach that keep kids safe when they're in the water, and these are the very same things that keep a program from drifting when you implement it. So one is our parents. So our parents are akin to an administrative champion. If our parents had never taken their eyes off of us, it would have been a simple task. If they had seen us begin to drift, they would have made eye contact, and they would have pointed, and with a sweep of their hand, they would have indicated that we needed to swim back to our position, and we would have done so. Programs don't drift when administrative champions keep their eye on them. They only can drift when someone who is responsible and has authority isn't seeing that it's happening. Drift doesn't happen all at once. It happens gradually, and it can't happen if there's an administrative champion who's really keeping their eye on it. So that's number 1. Number 2 is even if your parents don't see you drifting, at the beaches we were at, there were the tall white chairs with the lifeguards. The lifeguards were sitting at the top of these chairs, and they were keeping an eye on the swimmers. And if they saw somebody having trouble, they would go out and get you. In this example, your lifeguard is your trauma-focused CBT supervisors. And I didn't discuss this at length, but the developers of trauma-focused CBT have a special higher level of training for supervisors. Or you can have a very experienced trauma-focused CBT clinician who becomes a trauma-focused CBT supervisor as a role, as opposed to literally a supervisor of staff in your agency. And people who hold that role, they're like super strong swimmers. They're like lifeguards. And they run your trauma-focused CBT-specific supervision, and they make sure everyone is staying on the model. You're using the brief practice checklist. They're checking it. They're talking to you about sessions, accommodations, and how to make the model successful, dealing with cows and the crisis of the weeks. The third thing they had at the beach where we were at were these ropes with buoys that floated, and they stretched out into the water. And as we were drifting, they separated where the swimmers were allowed to be versus the surfers. And if you bumped up against the rope, you knew you had drifted to the edge of the swimming area. The ropes with the buoys are, in fact, your fidelity and outcome tools. They are your brief practice checklist, your PTSDRI. If you are administering them and you are not showing improvement, and staff aren't indicated they're doing the techniques, then you're not doing the model. You have bumped up against the buoy. If you're not collecting the measures, you have no rope and buoy. So drift occurs when parents aren't watching, when lifeguards aren't on the beach, and when there are no ropes and buoys to let you know you have drifted. And what happens is you wake up 6 months, 1 year later, and your program isn't where you last left it. So if there are 3 things that are really critical in our experience, it's those three things. I think that brings us to our questions and discussions.
Well, thank you, Dr. Sonsa. Excellent. Appreciate
Sure.
the in-depth discussion and the practical examples as well, and your use of metaphors. Certainly made it very interesting for us and brought it to a different reality. So we appreciate that very much. I know one of the questions that came in was an inquiry about the materials that you mentioned if someone didn't receive them, the checklist, the study. So we will post those on the CFF website in 2 slides from now. We'll give you that website address. For those of you that are regional partnership grantees, we'll also post this webinar on collaborative project management, and you know how to access that.
Okay, and I should clarify that report from CIMH is not a study. That report comes out every 6 months and has come out every 6 months for about 5 years. It is a routine process of evaluating performance of trauma-focused CBT sites. And the report I sent is an aggregate statewide report, but every agency listed gets their own agency-level report, so they can compare their performance against the statewide average. I'm just making the distinction because a study sounds like it's a one-time thing,
right,
and that report is ongoing.
Thank you for that. Appreciate that.
Sure.
And it can be a valuable resource to benchmark your individual agency's performance against an aggregate performance with as many providers as Dr. Sonsa has talked about in California. And
correct, and you could look at things like, is our dropout rate high? Is our length of treatment long? Is our level of improvement on the PTSD-RI lower? Like, how do we stack up in some key indicators?
Very good, yep. Mariana, are there any other questions that we'd like to pose to Dr. Sonsa that have come in since the webinar has started?
I think we have one more, and out of respect for time, this will probably be the final question. And this one, Dr. Sonsa, is just that we know many of the sites online are working with different partners, whether it's court partners or child welfare providers. And we're wondering what kind of information or what level of information you might share back with those referring parties about the kids and services.
Sure. So that's a kind of a tricky question, and not specific to trauma-focused CBT, which is, you know, when individuals who are involved with the court for one reason or another, dependents, wards, what have you, caregivers trying to get back custody or trying to keep from having their kids removed. So a lot of pressure around that, and I think that there's a distinction to be made between sharing information about the degree to which a person is actively participating in some kind of service, which I think is fairly routine and not controversial, versus some commentary on the level of, you know, overall effectiveness, like I think they're trying hard, or I don't think they're trying hard, or they're making significant progress, or something, which I think is more controversial. One is because I think that, you know, it not only speaks to is the person attending and participating, but also are they benefiting? I think that's a harder, more controversial question to answer. And I think particularly in the case of court-involved kids, lots at stake. The other issue unique to trauma-focused CBT is whether or not the trauma narrative should be shared. And I think there's a lot of caution around that. That again, if you're talking about did a person participate in treatment, yes, they've attended, yes, they've completed all of the expected components, that's fairly non-controversial. There have been questions about trauma narratives being in the mental health record, becoming subpoenaed, being used in court proceedings, particularly if there are prosecutions. And I think it's the developers of the model generally take the view that this is meant for treatment, not meant for prosecution or court proceedings, and that the procedure for gathering forensic evidence about abuse or maltreatment is different than what one does in treatment. The context is very different. So there are some concerns about that. People assume that what's in a trauma narrative is necessarily, you know, something that would be suitable for court hearings, and the developers would suggest not. So I think that in that regard, the trauma narrative in particular, there are questions about where that's maintained and what's made available in regards to any court proceedings. Does that make sense?
Yes. Thank you, Dr. Sosna.
Thank you. Okay, we're about to wrap up. On the next slide, I've got an announcement for our next webinar. Save the date for our next webinar, which will be June 24th. And that continues our evidence-based practice implementation webinar series, and it will be implementation of nurturing program for families in substance abuse treatment and recovery. So you see the date and time. And it will be delivered by Terry Bogage and Diana Christmas from the Institute in Health and Recovery in Boston, Massachusetts. And you see the registration link on the slides I mentioned. As I mentioned a few minutes ago, these slides will be available on the CFF website as well as the full webinar. And we will be sending this out as well on our Children and Family Futures newsletter, and we make these announcements as well to all the grantees that we work with, regional partnership grantees, and the other sites that we work with. And then the final slide has contact information for the National Center, where you can see the resources available to you through the National Center, as well as Mariana Corona. I want to thank Mariana for, she's the voice you've been hearing asking the questions and introducing this webinar today, and thank Mariana for her work in putting this together. And you can see if you've got questions for us, if you've got questions that perhaps Dr. Sosna could help with, feel free to forward those to Mariana. And you see, again, the link for where the website is. Todd, I want to thank you very much for a tremendously informative and helpful presentation. We appreciate your willingness to do that. We certainly appreciate the support of the National Child Traumatic Stress Network. So thank you very much. Elaine Stead, our Federal Project Officer, thanks for your support and for the Children's Bureau's support and SAMHSA support in allowing us to continue to provide these webinars through the National Center on Substance Abuse and Child Welfare. And finally, thank you all for participating. Those of us that are organizers and panelists are able to see the attendee list and able to see the number of attendees, and we absolutely had no drop-off throughout this presentation. So we appreciate your time and your willingness to take time out of your busy schedule to participate, to listen to this webinar, and we hope that that through that time well spent, it will enhance your effectiveness in delivering trauma-focused CBT and other evidence-based practices on behalf of the children and families that you serve and that we're all committed to serving. Thanks again, and have a great week.